What I know now, if you have a cancer diagnosis within 10 years of having children, you are actually a postpartum breast cancer patient. Postpartum breast cancer patients are significantly more likely to have a recurrence 10 to 15 years later. My recurrence was 13 years later. And not only that, but stage 1 patients, one of the earliest stages, those patients are more likely, 3 times more likely for metastasis and to end in death than later stage patients. And I think it's because
I have a really, really cool guest here, guys. And to be honest, I'm not sure if we'll get through oncology today. We'll find out. But I have Marybeth with us today. Hi.
Hi. Thank you for having me.
Maybe we can start with the organization you founded. Can you tell us about the organization and what made you found it?
Yeah, sure. So I founded Outperform Cancer, and Outperform Cancer was born from frustration that I had with the current healthcare system. And I want to say right up front, I love my doctors. I love the nurses. I can't say enough great things about all the people that I deal with and that I've met. So it's not healthcare per se. It's that there is a gap that I identified between what researchers, meaning cancer researchers, know and what patients know. Because unless something is established as the standard of care, nobody ever hears about it. And as a former researcher myself, not clinical, but market research, I know that there are great things that often collect dust and are forgotten. And I found so many incredible nuggets, things that could influence the outcomes of cancer patients, but that weren't being used. And I wanted to figure out ways to identify them, make them actionable, and bring them to patients.
Can you give us an example of one such thing that got you frustrated?
Sure. There's many examples. I think the lowest hanging fruit I'm going to give as an example is just exercise. Everybody knows that exercise is good for you. And I don't think anybody is going to argue with that. But most cancer patients do not get spoken to about exercise by their oncologist. And if they do, they tend to say that exercise can help them deal with fatigue and improve their overall quality of life. And those things are both true. But as a metastatic breast cancer patient myself, what frustrated me was that no one told me that I could get a 30 to 50% reduction in the risk of recurrence of cancer if I exercised. And to me, I'm like, hey, guess what? Surviving? When you're a metastatic breast cancer patient, the number one thing I'm concerned with isn't fatigue right now, right? It's surviving. So for someone not to know that they could receive that sort of benefit to me was upsetting. And I did some further research. Here's the thing that blew my mind. Anastrozole, a drug that I take for estrogen positive breast cancer. I'm HER2 positive and estrogen positive. So anastrozole, a drug that I take, reduces the risk of recurrence of my cancer by 46%. So when you look at that number compared to the 30 to 50% risk reduction that I can get from exercise, I'm like, why wouldn't I do both? I want all of those reductions in risk. I want to layer those on. So that's really the crux of why I started Outperform Cancer, because that's one example, but there are many, 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 many more.
Can we go back to diagnosis? Can you tell us about diagnosis? What happened? How do you get diagnosed?
Well, I think that you and I share a lot in common. Another thing we share in common is our diagnoses were in 2020, right? So May 1, 2020, I was having chest heaviness. And I knew from working in healthcare that women can present differently with heart attacks. And I just felt this real heaviness on my chest. And I felt like, I don't know what this is. I had COVID. It was in the height of just COVID hysteria. It was, May 1, 2020. So I went into the emergency room and they did an ultrasound and they saw that I had a liter of fluid on my heart. And I am not a big person. I'm 5'3" on a good day, and 120 pounds. So I'm not a giant person. And so a liter of fluid on my heart was a lot of fluid. So much so that they were worried that I might go into cardiac arrest. So they checked me into the hospital, and at their first opportunity, they drained the fluid. When they drained the fluid, they did find abnormal cells, meaning cancerous cells, in that fluid. And that kind of precipitated the whole diagnosis of metastatic breast cancer. I had stage 0, and I will say stage 0 breast cancer in 2007. And I want everyone to know that, so that all you patients out there realize that stage 0 needs to be paid attention to, just like any other stage. Because 13 years later, my stage 0 became metastatic breast cancer, and it really knocked me for a loop.
Can we go back to 2007?
Sure.
Stage 0, what did you do?
Well, stage 0, it was interesting because I did not know then what I know now. What I know now is that if you have a cancer diagnosis within 10 years of having children, you are actually a postpartum breast cancer patient. And postpartum breast cancer patients are significantly more likely to have a recurrence 10 to 15 years later. My recurrence was 13 years later. And not only that, but stage 1 patients, stage 1, so one of the earliest stages, those patients are more likely to have metastasis and death by X. 3 times more likely for metastasis and to end in death than later stage patients. And I think it's because at the time in 2007, they're a little bit better about this now, but they were hesitant to overtreat, right? So when I was diagnosed with stage 0, we tried to treat it with a lumpectomy, didn't get clean margins, so I had a mastectomy. Bilateral mastectomy. And then I did not require any radiation, no hormone treatment, nothing, even though we knew it was hormone positive. So, I think part of it is, they were treating it like all other breast cancer patients, whether you're 70 or, in my case, I had just turned 40. I was 39 when I was diagnosed. And I think perhaps the risk factors, or not just perhaps, research shows that the risk factors when you're diagnosed after breastfeeding, after having children, you do have a significant risk factor.
Interesting. How old were you when you first got diagnosed?
I was 39, and I had the bilateral mastectomy on my 40th birthday.
Oh,
I know. It sucked.
Oh, okay.
I had a 1-year-old and a 3-year-old. I have 2 beautiful boys who now are far more grown up. But at the time in 2007, my youngest just turned 2 and my oldest was 4.
Wow. Okay.
Yeah.
And then 13
and I
years
was
later,
working too, like so many other women.
Yes. Okay, so 13 years later, you go in for chest discomfort, and that becomes a metastatic diagnosis, but this time it's triple positive, so different from the first one.
No, the first one, the problem was because it's stage 0, they didn't have enough cells they had some microinvasion that they could test, that they could tell it was ER positive, but they couldn't, and they could see that they thought it was HER2 positive, but they didn't have enough to do the FISH test to confirm HER2 positivity. But really, they think it's the same one, and really it was the same subtype, triple positive.
I see. Wow. Okay. All right. Interesting. I think I finally understand, not finally, but I think I understand your frustration. I think if I had gone through something similar, I can see myself reacting in a very similar way. I think I understand it because in 2007, we didn't have the HER2 diversity that we have today. HER2 low, we don't have any of that.
No.
That was all relatively new. The entire class of hormone positive treatment, that we have so many drugs now, that was barely anything, if I remember right.
Correct.
So even that, the landscape has shifted so dramatically that.
Right. And I'm so happy for the newer diagnosed patients. I just want to say, hopefully you will have dramatically different outcomes because you have so many more tools, and a lot of different things have happened, as you were just saying. It's true.
Okay. So you go through this thing, and then when does Outperform Cancer get founded?
It took a while. I was floundering because I didn't have a roadmap for my care. Manticares did not exist yet. So I was trying to project manage my own care and trying to figure out how to navigate the system. And even though I had spent more than a decade writing strategic plans for hospitals and really understanding how they work, it is different when it's your care, and it was different because it was COVID. So there were a lot of rules that were different. Yeah. So I had the diagnosis was 2020, and then as soon as I kind of became stable, which was by later that year, so by the end of 2020, I started to ask my doctor, okay, what else you got? And she was like, what are you talking about? I said, what else do you have? I'm a motivated person that can be disciplined. I can take direction. You tell me, what else do I have to do? And she goes, I don't know what you're talking about. She's like, take the drugs, right? Like in a very nice way, take the drugs and go home, right? And I just believed in my core that there had to be other things that would push me on the far side of the bell curve, right? The bell curve is that statistical curve that says, what your 5-year, the statistics associated with your 5-year survival. And I wanted to live. And I thought, well, there's somebody at the far end of that bell curve. It might as well be me, right? So I started to think about what could I do to get there. And to be honest, I had started looking at that as soon as the diagnosis happened. I was making phone calls and looking at research and things like that. But it didn't turn into something that gelled like maybe I need to keep better records and maybe I need to share what I'm learning with other people. The more that I reached out to researchers, the more they spent time with me. And the more I felt like I'm using the precious time of this person, I need to share this with other patients. And that's when it became Outperform Cancer, because I just felt like it took me so long to come up with what is a robust anti-cancer strategy that was backed up by peer-reviewed research in high-impact journals. What does that mean? It means that we know the research has been deemed sound and good research by the research community. And there's so much noise out there for cancer patients. It took me a long time to sift through it. Now things are getting way easier with AI. What took me 2 months, in 2020 would take 2 hours with AI.
You and I are incredibly similar. Very, very similar. By the way, that basically means that 5 years just happened for you, didn't it?
Yeah, actually 6.
6. I was like, depending on how you count it, because for me it was end of Herceptin, but in my head it's 5 years. But
yeah, I mean, from the evidence so I have no evidence of active disease right now, and I haven't had any active disease since November of 2020.
Wow.
So depending if you count the time that I was initially diagnosed with the disease, which was May, or when we did the scan and showed that, I wasn't lighting up like a Christmas tree anymore. Things went rapidly for me, meaning when I presented with disease, as I said, I had it in my heart. I also had lesions on my skull. I had it all in my spine, in lymph nodes everywhere, in my hips, in my pelvic bone, in my ribs. So there was a lot of activity. But when I got on the drugs and I started to employ all these strategies right away, right? I started to exercise. I changed my diet. I changed my sleep patterns, which previously were not very good. It is still an Achilles heel for me, to be honest, but I did a good job on my sleep. And then I started to identify other strategies that were backed up in research as well. And when I started layering those on, I do think that that helped me to get to know evidence of disease very quickly with the drugs that I was on, but always in partnership with standard of care.
That is awesome. That is awesome. The reason you see me hesitate is I think there's something really powerful in what you just said, not just about the standard of care side, but also you went from being diagnosed with metastatic disease in May to NED in 6 months, 7 months?
I didn't start getting treatment until July 15th. So wow. I actually went 10 weeks without treatment, which that's a whole nother thing. I think it should have gone much faster. But again, it was COVID, so we'll give some leeway there. But it was really happened between mid-July and November.
That is incredible.
Mm-hmm.
And this was all oral for you?
No. Standard of care for triple positive was a Taxol. So I did Paxlotaxel. I did trastuzumab and Perjeta. And then once the Paxlotaxel was done, I was given anastrozole, which is an aromatase inhibitor, to have with the infusions of trastuzumab and Perjeta. And I continue to this day to get that infusion of trastuzumab and Perjeta, and I continue to take an oral aromatase inhibitor called anastrozole.
So you're still on a 3-week infusion cycle? 3 week?
Correct. Yes, that's right.
All right. But you're here.
But I'm here and I'm so grateful. And yes, it's a combination. I think it's a combination of lots of things, but the drugs do the heavy lifting. And anyone out there who's hesitant and thinks, gee, maybe I can do this on my own. Maybe I don't need medical help. Maybe I don't need these drugs. I would say, please, please, please use all the tools in the toolbox. This is not a disease that you want to mess with and not put everything that you have at it right out of the starting gate. You are much more likely to have good result if you really start hard charging from the beginning. And the heavy lifting, you can plus things up for sure, but the heavy lifting comes from the drugs.
Can we talk about the modalities of anti-cancer treatment that you relied on outside of medication? So what I've heard you say so far: exercise, sleep. I imagine nutrition is somewhere in there.
Nutrition is a big part of it. I eat fish occasionally, but primarily a vegetarian. I don't have very much dairy. But I don't go so far as to say that I'm vegan, because I will have a little here and there. But I'm very considered with what I put into my body. And the reason is that our bodies are one big chemistry experiment, right? Everything we do changes the chemistry. And you can change your chemistry to be helpful for cancer growth or harmful for cancer growth. And I choose to make it an environment that is going to make it really hard for cancer to grow. And there's a whole bunch of evidence supporting that. It says, yeah, that probably makes sense. Right down to stress. So I actually did leave a job that I had as the chief operating officer of a marine robotics company, where I helped build this company, and it's flourishing. I'm happy to say I'm still very good friends with my former business partner and CEO. But it was a heavy lift. Entrepreneurial ventures usually are. So I took a step back from that to try to keep my stress levels lower. And I also started investigating off-label drugs. And I will say, I think patients need to be really careful about this because there's a lot of bad information out there. But there are some reasons to look at existing drugs to see if they can be beneficial. I'm going to give you 2 examples if I can. The first example comes from a clinical trial called the PATINA trial. This trial was first reported, the outcomes of this trial were first reported in 2024 at the San Antonio Breast Cancer Conference. And at that time, they had data that showed that by adding, for triple positive breast cancer patients like me, by adding a CDK4/6 inhibitor, so that at the time was Ibrance in this study. So the Ibrance drug, by just simply adding that drug to my current regimen, that those triple positive breast cancer patients could get a 50% improvement in progression-free survival. That's pretty big. They still don't even have overall survival data yet because people are living so long. So here we have data where we know this is a phase 3 trial now done out of Dana-Farber, high quality research. And we know that if we take an already FDA approved drug called Ibrance that estrogen positive breast cancer patients already use, and we give that same FDA approved drug to estrogen positive and HER2 positive patients, those HER2 positive, triple positive patients get a 50% improved progression-free survival. Now that drug is considered off-label if my doctor was to give that to me right now.
Yes.
Because it's not standard of care. But we know the information, we know the data, and the data is really solid. And I like to do something called loose math. Loose math for me is like, okay, let's get in the right ballpark, right? So I did some loose math based on when we as researchers knew the results of this study and the number of patients today who have been newly diagnosed. So I didn't even count people like me that could benefit. Only talking about newly diagnosed patients who are triple positive who could benefit from this quote unquote off-label drug. And that is almost 17,000 progression-free survival years lost. 17,000 progression-free survival years lost. And those are good years because this is first-line therapy. So very few side effects. People usually feel pretty good on this regimen. And still, unfortunately, it's an off-label drug.
So let's talk about that, right? Because I think it's a really good example. It's a very good example. And the more you talk, I'm like, oh my God, we are so eerily similar. We are so similar. I am not even joking. I definitely remember advocating for, when I was going through it, for a class of therapy that was not on label yet, that was in trial, that had been shown in a different setting. Anyway, short version is I drove my care team a little bit nuts because I was kind of advocating for use in me and it wasn't in a trial. Short version is fully relate. But let's talk about it from a super practical perspective. Say you are a triple positive metastatic breast cancer patient today and you do your research. You figure out through, 1 hour of searching, it should show up pretty quickly because this is a published trial, that the drug exists, it's available, and you go to your doc. What happens?
It depends on the doc, because I have talked to docs at MD Anderson who I feel that particular organization is very far forward. I think they're on the cutting edge. Honestly, I can't say enough good things. But even doctors all over the rest of the country, it's kind of like teachers. You're going to have some that you resonate with and that are on the cutting edge, and have other ones that maybe don't. So I would say make sure that you have a doctor that you're working with that is resonating with you. And then I would say a lot of times the doctors will say it's not approved for you, and they might say insurance is not going to cover it because it's not standard of care. My plea is don't give up. Don't just take no as an answer and continue to push. Go to the drug manufacturer. Ibrance is manufactured, I believe, by Pfizer. So call up the Pfizer team and say that you would like compassionate use of this drug, and don't take no for an answer. The data is there. So make them really think about this.
So in addition to going to Pfizer, how would you advocate with a doc?
It's tough. I mean, I would ask questions you might feel like you already know the answer to, but I would ask it as a question in a non-threatening way to see if you can get them on board to fight for you, because that's everything. You've got to get the doctor fighting that battle. If a doctor says that this is necessary, medically necessary for you, the patient, then most of the time they can get insurance to agree to, push this forward. But you've got to get the doctor that's going to be on board. And so phrase it as a question. Do you think this could help me? Are you familiar with this data? What do you think would happen for my case if you were to know this data? Things like that.
Marybeth, you're literally talking about why we named the podcast what we did, by the way. I'm even joking.
Are you saying I'm a patient from hell too?
Actually, in this moment, yeah, I really am pushing for off-label use because the data is out. Yes, I would put you in the category. All joking aside, though, the person, it's named after a book. So we named the podcast in homage of a survivor. And Stanford professor got diagnosed with a super rare form of cancer, and then goes through treatment and ends up writing this book called The Patient from Hell: How to Get the Best of Medicine. And the thesis of the book is that in healthcare broadly, medicine broadly, the way studies are done is in cohorts, right? You put the patient into a cohort, a group, you compare group A to group B. Group A gets something, group B gets something, and you're doing a comparison. That's how studies are done. Now, when you go into getting actual care, it's exactly the same thing, right? Patient shows up, patient is put into a bucket, and based on how that bucket was treated, in the trial, presumably, standard of care reflects that. The problem is, one, there's a lag between to the point between research and actual use. And the second is
a 15-year lag.
And the second is clinicians are not trained to think empirically, right? They're not taught to think in enough.
Yes.
The training in medicine is done on a population level. It is not done on an individual level, which basically means that regardless of what you are dealing with, you as a patient in oncology, more likely than not, are in an N of 1 category. More likely than not, you're N of 1. If you look at age, demographic, biomarker, site of care, just add up all of the variables we have at play, you're pretty much N of 1, which means that you have to push the system, otherwise you will not get the best of medicine.
That's right. That is absolutely right. And I'm going to give you the second example I was going to give you fits really well with what you were just saying.
Ready?
There was research done on whether metformin would help cancer patients. And there was a phase 2 trial, and the phase 2 trial was followed by a phase 3 trial. And the phase 3, randomized, placebo-controlled, blah, 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 found that metformin on a whole was not particularly helpful. They did not see that as beneficial for breast cancer patients. And this was against patients who did not have diabetes. So this was just breast cancer patients, otherwise healthy, that they gave metformin to as an extra drug to standard of care. So they still had standard of care to see if there was any additional benefit. And they did not see it benefit as a whole. The exception was HER positive breast cancer patients with the C allele on the ATM gene. If you had the C allele on the ATM gene, they found a significant benefit that I'm trying to think. I think it was like 60%, 50%, 60%. And for progression-free survival, and even bigger for overall survival. So, my feeling about that was like, okay, I'm a HER2 positive breast cancer patient. Maybe I should see if I have a C allele on my ATM gene. So I go to my doctor and I said, hey, can I find out if I have a C allele on my ATM gene? And she looked at me like I was crazy.
I really, when you started out, I was like, oh man, I wanted to be a fly on this wall in this office.
Right?
This conversation goes down.
It was very funny. And she goes, I don't really know. So I called up an oncoproteomic specialist that I had interviewed for my podcast. And she was in Amsterdam. And I was like, Connie, how do I find this out? And she goes, oh, she's like, that's easy. She goes, go to this company, iGene, and for less than $300, I found out that indeed I do have the C allele on the ATM gene. So for me, it seems to make sense to, to take metformin in addition to my standard of care. Now, would I have done that if I did not have the C allele? No, because the data showed that, that wasn't really helpful. But for those people who do, I'm just looking at here on the actual results. The trial was called the MA32 randomized clinical trial. And yes, there was a 50% reduction in recurrence or invasive disease events and a 65% reduction in risk of death. It's the second part of that really got me. I would like a 65% reduction in risk of death as a metastatic patient. That's the second example. I mean, these things exist out there. Some researcher knows this.
Yeah.
Right?
Yes. I'm looking at the clock and I'm like, oh my God, you and I can definitely talk for hours. And we can probably start wrapping up. But I guess I have one question before we go into a wrap up. I wonder if you want to address cumulative interventions. I say that because most studies are done on an intervention by intervention basis, right? So for example, exercise works group A versus group B. Nutrition works group A, group B. Stress reduction, I'm picking on mindfulness-based stress reduction, alcohol reduction. Like you have all of these studies. They're done sometimes randomized controls, sometimes not gold standard studies. Sometimes they're done in smaller populations. Sometimes they're done not in a population that mimics your ethnography or race. So when we are sitting there looking at all these studies, just in the examples we've covered, right? Stacking benefit is effectively unproven.
Correct.
For the most part. Yeah. So you're effectively doing a series of experiments in yourself.
That is correct. Yes. And I think it's really good to point out because every patient has to look inside themselves and figure out what your risk tolerance is. Standard of care is designed to be the safest, best, most proven path forward. And I applaud that. I applaud it. For me personally, I would rather take a risk in hopes that I'll have a bigger reward. And, I just listened to a man named Sid Sibrangi, he was the founder of GitLab, sold his company. He's a billionaire. He got a sarcoma. And after going through standard of care and having him get to a point where they said, there's nothing more we can do for you, he had to take matters into his own hands. There wasn't anything that the medical community was going to do. So he did. Now he has the resources of $1 billion, but a lot of the stuff that he did doesn't cost $1 billion. You can do it with biomarker testing, and AI can get you pretty far. And that was what he said in this recent meeting that I was in, where he was talking to us about his story. But one of the other things he said that I thought was interesting is he said, I would rather die from taking a risk on a drug than die from cancer. And I understood that because to me, it was like, okay, if I go down, I'm going down swinging. I'm going to try to fight as best I can. And I know some people don't like to say fight cancer. And I don't mean that in I feel a lot of peace. I'm a very spiritual person. I believe in God, and that has helped me through this. There's no doubt. But I want to try. It's in my DNA to try to problem solve and figure stuff out. And when I look at what we can know in biomarker testing, and I look at the success of David Fajgenbaum, which if you haven't seen the TED Talk, everyone out there, stop right now, go to YouTube and listen to his TED Talk. It is phenomenal. He's my hero. Sid is my other hero. These are people that took matters into their own hands, and they started with like, well, what do we know? And then they used applied logic. I feel okay with that. I'm not going to just try things willy-nilly, but if there's a solid reason, I feel good about making that choice. It feels like an educated decision. So, it's a gray area. A lot in cancer is a gray area. Standard of care is a gray area. So I just encourage people to, always rely on standard of care. And then look in your heart and figure out, do you want to be more conservative, which is fine. No, I think that truly is, a fine way to go. It just wasn't the way I wanted to go. And, Sid, as I was giving his example, he's now 3 years with no evidence of disease. And that was from when they told him, hey, there's nothing more we can do for you. And now here he is with no evidence of disease. And I really feel like, you know what? There's a lot more we can do for ourselves. It just hasn't been proven with a phase 3 trial yet. And I'm not willing to give up all that information just because it hasn't been through a trial.
Marybeth, thank you so much for being on the show. I feel as a kindred soul, so thank you.
I think we are. You are welcome. I've really enjoyed myself, and thank you for the opportunity of having me here.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares